We're delving into female hair transplants, the intricacies of long hair follicular unit extraction, FUE for short, and the future role of stem cell technology in hair transplants. Leading our exploration is Dr. Marie Shambach, a renowned hair surgeon and the founder of the Shambach Hair Clinic in Guatemala. As a former president of the Ibero-Latin American Hair Transplant Society and an active member of the International Society of Hair Restoration Surgery, her insights are invaluable. Dr. Shambach, welcome.
Thank you so much, Hannah. And I apologize not only for my English, but living in a third world country, sometimes my internet is not the best. So bear with me if you see some pixelation or some, so slow connection or whatever.
No problem at all. So let's get started. Let's first start our conversation talking about female hair transplants. In light of advancements in hair transplant techniques, could you share your insights on how these have evolved for female patients?
Sure. Usually, the preferred method by most doctors to do a hair transplant in women would be with LSE or FUT. That means linear strip excision or follicular unit transplantation by a strip excision. This way, you don't have to shave the patient. Usually, as women, we take care a lot of our hair, and it takes a long time to grow it and grow it healthy. So when you approach a patient that actually wants to have a hair transplant, and you go around saying, "Oh yeah, sure, I just have to shave the back part of your head," it's not something that's going to be, very appetizable for any female patient. So the two options that are left is either the linear strip excision, where you take a strip of skin and then you sliver and you get all your grafts from the most healthy, non-androgen sensitive area, which is the donor area, and you get your grafts and then you place them. And now, because of the influence of the new era where everything is about follicular unit excision and not wanting to have a scar or a better recovery time, a sort of less painful procedure, less invasive, etc. There's also a choice of doing FUE, follicular unit excision, but without shaving the head. That means there are two ways. You can either do, it doesn't have a specific name so far, but you can do a non-shaved FUE where the punch, while it's doing the excision, cuts the hair shaft. So you choose the follicular unit you want to extract or excise, and when you place the punch, you create the movement so the hair shaft gets cut while you're doing the excision. So you are only going to cut the hairs that you're going to extract. And you get short hair grafts and then just place them as a regular hair transplant. The other option is to do a long hair FUE, and that means that you extract the complete graft or the follicular unit with a long strand of hair, and then you place it with long hair, so you sort of get to see a preview of how the design is going to look, which by far it's my favorite technique, because at the beginning it's hard to get the manual ability to do this surgery, but we can be as good as 2,000 grafts per surgery per day, and get a beautiful design where the patient can even participate in the density, and sort of they are looking how the new image is getting created. You can do long hair also with the linear strip excision. Also, that's been done for a lot of years, and that was done by several doctors before. The concept of preview long hair FUE was done by Marcelo Pichon in Brazil, and he started doing linear strip excision with long hair. And then when FUE came, and it was a big renovation of the techniques, and we started exploring the possibility of doing FUE with long hair. So by far, that would be my favorite, but still, strip, it's a very, very useful and safe technique to give the best grafts to the patient.
And what do you believe the limitations for the long hair procedure are? Because I would imagine it's obviously if you shave the hair, which women don't obviously prefer, it's much easier to visualize the hair follicles and see, your field better. But when you have long hair like we do, it's much harder to visualize that. So, what are the limitations here?
Well, like I said, the limitation would be the curve of learning how to do long hair. We have seen that grafts are pretty much the same in terms of health. We did a study where we compared long hair versus shaved FUE, and transaction rates are pretty much the same. The coefficient of hair per graft is it's also very good. So the limitation would be the time it takes. It's just a little longer than regular shaved FUE because you have to, I mean, these hairs can tangle, and there's some things that you have to do. For example, it's very hard to place long hair grafts when the hair shaft is more than 7 centimeters. And you can create that illusion of density creation by using just 3 inches of hair, and it's going to be easier to take care of it. But the limitation would be time. So if you're not proficient in doing long hair FUE, you can definitely do long hair LSE. Or if the patient is used to having short hair, shaving only the lower part, when it's also feasible. I think that it comes to ethics in whether you should tell your patient these are your options and I'm really good at doing this, but probably this other option is better for you, and this is a list of doctors that can actually do it very good. So I would definitely put out all the options and then let the patient decide.
Are you concerned at all about over harvesting in this with this technique?
Not at all. Actually, when you are doing long hair, you can see if you are exceeding the limit or not. When it's shaved, you're just mathematically assuming by doing the coverage value. So you can calculate with a shaved patient how many grafts I can extract per square centimeter before depleting the area. But with long hair, we've seen that we can stretch it or bringing it shorter because the coverage value, even though it's a mathematical assumption, it's not taking into account the skin and hair color contrast. It's not taking into account the curl. So it's got limitations. But when you're doing it with long hair, you can actually see if you are exceeding the limit of how many you can extract. So it's a better way to manage uh, what would be the most that I can get out without thinning, or maybe a little less. And then just as you place them, you can also manage how to put them in certain way that it'll look thicker. So the study that we did, we actually had two squares compared in the same area, and we extracted the mathematical amount that we calculated by coverage value. So let's say I could extract 12 grafts per square centimeter. I'm just throwing a number there. And then when we turned into the long hair box, we would extract as many as we considered enough so we could leave enough coverage. And we saw that we could get a little more sometimes. In some patients, even though it was the same 12, sometimes you would take a little less because you could start seeing some thinning. And the same happens when you're placing them. So we programmed to place 35 grafts per square centimeter to get a dense pack, get it really dense. And then we figured out, we did the 35 in one box. And the next box, we said, okay, let's put enough hair so we could see coverage. And it was a lot less, a lot less. And it was like 18% less. So
Wow.
managing with long hair by visualizing what you're leaving or what you're taking out, it's a little less mathematical, but a little more ethical. Because there's a lot of variables in the mathematical formula that we're not taking into account.
And it seems to me like this is your preferred clinical method of using this technique on women is like really your preferred method. Is there any time that you would say this female patient is not a candidate for this?
Yes, of course. For example, a person that has a very extensive female pattern hair loss where you see a lot of hair loss going all the way down, but still you have a thick but thin area. I want to get the most grafts out of that thin area. That would be a linear strip excision, no doubt.
So it really depends on the distribution of her hair loss and where you find the most density.
Yes, definitely.
Okay. So this is a very exciting technique because not a lot of people are doing it. So it's very special to have Dr. Shambach here telling us about the long hair FUE technique. So let's just talk a little bit more. We'll go back and talk more about the FUE. So given that many practitioners are hesitant to perform follicular unit extraction on women, what is your philosophy?
I think it all comes to being honest on what your ability is and knowing that you have colleagues that are really good at doing some things that you can't. So I'm honest. I do a lot of FUE, a lot. I can do LSE, but I'm not the best. So I can tell my patients, probably the best option for you is this. I'm I can do it, but I know this doctor that are like really really good at doing this. So you are free to have a second opinion and get a second consultation with someone else. And this is my limitation. This is their advantage, and I'm pretty sure that they'll just go back and say, "I really like you because you're being honest," and then they'll work out with what we have. But still, I have a lot of patients that I just send them to colleagues in the States that I know that are really good, or Brazil, or I've had doctors send patients here, but the name Guatemala sort of scares them. So it's as long as you're being honest, I think there's no way to lose.
Yeah, and certainly you're built, it's very admirable because you're showing that your honesty is coming first and you're building patient trust. So it's very admirable of you. What are some of the main challenges that you encounter when doing hair transplants on women? Besides for what we already talked about with, not wanting to have to shave the hair.
So, since I do a lot of long hair FUE, the biggest challenge is how they take care of the post-op time. So I have to be very adamant in telling them not to pull the hair, not to comb it from the roots. They have to comb it from here downward because it's around 2 to 3 inches long. So you don't want to pull them at least for a week. So that process of explaining, I have them come to the office the next day, so I show them how to take care of their hair. But you would be surprised. They're so afraid of losing because they can look how hairy they look after the surgery. They really want to take care of it. But then that would be my biggest concern about how they take care of it after surgery, just not to pull it.
It's
And
so
you know,
funny. Not to cut you off, we'll go right back. But I remember when I was much younger, I think, a hairdresser. She told me, make sure you brush your hair from the bottom and work your way up, because she's like, if you have a knot at the top, you don't want to pull at the roots and bring your knot down. So brush the knots out as you go up. So it just made me think of that. But yeah, I want to hear, what are the other complications you encounter?
So the technique I use to place the grafts is with implanters. So sometimes when they are too long, I sort of when I place it inside, I sort of accidentally capture the hair shaft with my finger towards the implanter, and when I take out the implanter, I take the graft out. So I'm very adamant with my technicians to load the implanters with a curvature facing outward so I don't have to grab them back. And if it's just going crazy, I tell them go shorter, 2 inches. So I grab the implanter like really from the distal part and start placing. But it's at the beginning was crazy because I wanted to do like really long hair strands and counting the grafts in a big knot. It was crazy. So and or pulling them out. You pull them out and all the hairs go together. So we sort of came up with do-it-yourself little thingies to put the hairs inside with a glove. And we shared that video with the whole staff. Now there's a lot of people doing little rings with the
Mhm.
glove so they can put the hairs inside. It's really cool. So we've come with a lot of ideas. Not only me, my techs are geniuses. They put a comb so they can put the hair strands on the side and the grafts inside the holding solution. So there's a lot of I mean, your staff is usually very clever at doing this, but trying to be ambitious in having like really long hair, it's useless. So just what you want to see is scalp coverage and a little bit of volume, and you can achieve that with 2 or 3 inches. So just go a little smaller. Still, you'll have that preview of the density, and it'll be perfect.
So, leading up to a hair transplant for a female, do you typically pre-prescribe them medication like minoxidil, even maybe dutasteride? I'm just wondering about what your planning process looks like for a female hair transplant. And obviously, many people are coming to you where they're saying, you know what, Dr. Shambach, I've been on medication for a long time now. Yes, my hair is looks okay, but it's not where I want it to be, or my hairline is not where I want it to be anymore. Can you help me? So it's kind of like the last step. So I'm just curious what that looks like for you.
So it's funny because when I started my practice many years ago, I'm not gonna say how many years ago. Then I'm gonna, my Botox is doing perfect, so I don't want to show out my age. But when I started my practice, I assumed that the most population I would get here is men. And to my surprise, 70% of the consultation are female due to hair loss for any reason. And they come here as a first consultation. They've gone to a couple of derms, which are not very specialized on hair, and they just do minoxidil and they say, oh, well, it's just physiological. The most important thing is to get a proper diagnosis. Once you get the proper diagnosis, you never throw the hair transplant at the beginning. You want to leave the hair transplant as the last resort. You don't want to submit the patient into a potentially complication just because, oh, that's my specialty. The person that does hair transplant has to know about trichology and do a proper diagnosis. And if they don't, they should be allied or have an alliance with a dermatologist that will do a proper evaluation, trichoscopy, lab work, diagnosis, biopsy if needed. And then after having at least 1 year of treatment where you see, okay, everything is failing, that's when you say, okay, you know what, let's do a hair transplant because we've done everything and this is the best we can do for you medically. Now we go into surgery. So it should be like the last option.
Yeah, I think there are some hair transplant surgeons out there who are just don't feel super comfortable treating females, so oftentimes they turn females away. But that's why I said this is such a relevant topic. I know a lot of women who deal with hair loss, and sometimes they don't come to you until later on, where it's kind of progressed significantly. But and I think people always think like, you know, men are the ones that are always like trying to fix their hair, but it's not we have to remember in society it's not as acceptable for women to be aesthetically bald as it is for men. So I think it's a challenge, and obviously it's amazing that you have really mastered this area. So I want to go a little bit. We talked about FUE. I know that you're lately have become involved in Dr. Shambach.
Yes, I'm here. I'm here.
Okay, I think your video may have turned off.
Sorry. Internet, crazy country. Probably just the wind passed on and took away this thing, but it's gonna come back. I'm getting better signal right now.
Okay, no problem.
Back
So I
there now?
know that what?
I can see you. Is my
Okay.
video back on?
No, I hear you, but your video is not on. So
I
I
don't
know that you've your clinic is starting to work on hair clone technology. And I would like to learn about your involvement with this and regarding this emerging hair clone technology, what aspects do you find most promising? We know that cloning has been spoken about for many years now. So I'm just wondering where you see things at this current time, and how do you see it altering the future of hair restoration?
Okay, sure. I am super excited about this thing. I really think this is a game changer. Um, we've been waiting for this for a long, long time, 10, 12 years, what they've been talking about. Hair cloning is coming. We know we can clone. At the beginning, they were trying to clone the whole follicular unit, and there's so many cells involved in there with so many interactions between each other and movements. And it's creating an organelle so complicated would be really, really hard. They're even trying to do 3D printing of stem cells and some, create a whole organelle and still getting the right direction of growth and the cycles. It's very complicated. So when we got to this point where I found these amazing studies done by this company that actually they can separate the dermopapilla cells and actually clone them. And it's been proven already that if a hair is miniaturizing and the dermopapilla cells are reducing in amount or in numbers, when you inject dermopapilla cells, they'll migrate into that dermopapilla and make it thick again. But imagine this: if you get dermopapilla cells from the area where there's no or less sensitivity to DHT, and you clone these cells that have less androgen sensitivity, and then you transplant them into the dermophilas that are DHT sensitive, and you sort of convert gradually that hair follicle into non-androgen sensitive. I think surgeons are about to get out of work. The thing is that it's very promising, and most of the steps have been proven. So we're at a point where we know that we can bank these follicles. So the younger the follicle is, the better capacity of cloning it has. It has more energy, more ability, the DNA is more preserved, etc., etc. So we are banking these follicles that not only have dermopapilla cells, it's got melanocytes, keratinocytes, and all these other cells that can be used in the future for other pathologies. Even there's studies trying to reverse graying of hair with the melanocytes that are present. So the importance is that this is already proven, it's going to work, and it's a matter of automatizing the process so it becomes accessible financially. And that's just a matter of time. And it's not a new study that we have to do. It's all been proven. It's just getting those follicles, bank them, complete all the processes that we need, and we're going to be able to eventually not only thicken your hair but make it less sensitive to DHT. I think my grandkids are not going to be bald.
This is very exciting, and it's been spoken about for many years about how to stop the progression of your hair, I should say the loss of color in your hair and making it gray. Everyone's been trying to crack the code on that. So, if this technology can do that, this is a game changer. And it really makes you said that younger follicles are better, and it really makes me think. We're in this generation where young people are told to freeze their eggs, and the younger you do it, the better. So, do you foresee a future where it's not only freeze your eggs, but freeze your dermopapilla cells?
For the past 20 years, we've been freezing our cord blood and there was no idea what was going to be useful for. Now we know. Now there's a lot of treatments that we can do with cord blood. So now we know that we can cryopreserve these follicles, and they have a potential to do a lot of things. And that we know that eventually we can get those hair cells, dermopapilla cells, and clone them in several amounts and just place them back to make your hair thicker. And it's totally accessible financially. I mean, it's not just for the big and rich. It's actually for people that have, the opportunity. They know that this follicle bank can exist. You put all your hairs there. It's just 100 hairs. You don't have to take much. If I do a surgery, I'll just, can I grab 100 and then just, freeze them and get them to this follicle bank? And probably in the future, near future, they're talking about 2 or 3 years. Maybe there's automatization. It's going to be cheaper, and I'm just going to put the cells back into your scalp. You're going to get thicker hair. And not only that, maybe someday we can stop finasteride or dutasteride. Yeah. There's even there's plans of being able to map the hair or map the scalp in terms of how sensitive, how androgen sensitive is each area, so you know where to inject the dermopapilla cells. But that's an even
because you'll want to inject it obviously in the areas that are more like sensitive to DHT and androgen.
clinically, you can go with your trichoscope and see wherever there's 20% thinning. You know that it's already happening. You know
Right.
that it's not going to work on already miniaturized hair. It's going to be too thin. Just getting back that dermopapilla working is going to be too hard. But the ones that are starting, so if you see 15%, 20% miniaturization, you know that it's happening already in that area. So you can sort of map clinically, but if you can do it like really DNA testing and cell testing and say, okay, this area needs right now, that would be better. But it's part of the process, and technology always goes faster. It's exponential. It's not linear.
So it sounds like the only limitations and challenges are like financial and, you know, if you have hairs that are already too far gone and,
Yeah,
past the point of mineralization.
yeah. So it's not all lost for all surgeons there.
You'll still have work. So do you have patients right now who are saying, Dr. Shambach, you could take 100 of my hairs and put them in the bank?
Especially kids from patients that I'm doing surgery. I'm telling them about this technology, and they say, well, my kid is 17, 18. I said, well, that's the perfect age because this is inherited, and eventually they're going to need it. And probably by the time that they're starting to lose hair, we can just do this and instead of doing the whole surgery. So
Wow.
that's the attractive side. But still, patients that are going to have um, radiation therapy or my God, my English is losing. I'm losing my English like I'm losing internet. Chemotherapy. Um, we're trying to see. It's been proven in male pattern hair loss, and they say it's really accessible. I might as well just try and put them, and then we'll see if we can get those dermopapilla cells back active. Still, you're putting the dermopapilla cells in there. It's not only about the DHT sensitivity; it's about repopulating the DP.
Yeah, and it might be have an application for someone who say like has a TE, a telogen effluvium. You might be able to kind of accelerate the process of the hair returning by injecting the dermopapilla cells.
Most of the studies have been done on pattern hair loss, but if you can get millions of cells, surely. The
It's
good
very
thing
exciting.
about the telogen effluvium is that if you do a proper diagnosis, most of them are treatable.
Right,
So
and most of it will come back over time. Well, Dr. Schambach, is there anything else you want to add to our very insightful conversation on women who may be interested in hair transplants?
yeah, sure. To to patients or to doctors? It's a different
Both.
message. Okay, to patients, just make sure that you have all the knowledge you have of the doctors that you're seeing and that you're confident that you're taking the right decision and that you've been already trying your medications. And even if it's not female pattern hair loss, even there's some types of hair loss that you want to wait before you do hair transplant. Just make sure that you make like this really digging in research in knowing that you have the right doctor for you. And I've seen that the best works is word of mouth. Make sure you talk to other patients that have gone there instead of just relying on internet. Internet today is scary, scary. Like, technology is so good and so bad sometimes. So just be very wary and have like real dig in information from other patients. That would be the most important. And to doctors, not to be afraid to try long hair. It's a really nice technique, and it's just hectic at the beginning. So I recommend most of the doctors that have come here to learn with me. What I tell them is, look, you're going to do a shaved FUE on a male person, anyways. So just leave one square with long hair and do that square with long hair FUE. And then you shave it. But still, you practiced. In every single patient, practice one box, then two boxes, and then increase the size. But still, you're going to shave them up to you get to a point. If you can do 1,000 grafts, then you can start doing small surgeries. And that's how it goes. That's how we all start, with small surgeries.
Well, thank you so much, Dr. Shambach. I appreciate your time today. I hope you enjoyed this episode of the Derm Club podcast. If you found the discussion today to be valuable, please subscribe and share. I look forward to seeing you in the next episode as we continue to delve into dermatology and skincare with the world experts.